Thank you, Justin, and thank you everyone for being here. Happy Veterans Day to all of our vets out there in the audience. My name is Cindy Slagle, and I'm the Vice President at Weatherby Healthcare, and it is my pleasure to be joined today by an expert team of healthcare leaders to have a robust discussion about the pandemic and the impact that it's had on recruitment, onboarding, retention, and staffing in general today and in the long term. So the goal of our panel today is to provide valuable insights, perspectives, and hopefully helpful tips around how hospitals, health systems, and recruiting teams across the country are adapting their staffing strategies to really maximize success, not only for today, but in the future. So before we get started, I have a few housekeeping items that I want to go over. As a reminder, you cannot be seen or heard. However, you will be able to ask questions through the Q&A feature at the bottom of your screen. So I'll be reviewing those as we throughout the discussion, and we'll try to answer as many of those questions as we can. And if for some reason you're having any technical difficulties, please submit those in the chat feature below. We do have support staff standing by to help you with those. And lastly, we are recording this session, so we will publish that as quickly as we can upon the finish, and you will receive an email link to the session as well as a short survey, which helps us figure out what topics are most valuable for you for future webinars. And that should be all of our housekeeping items. So next, I'd like to move on to introducing our diverse expert panelists today. And is my great pleasure to help you all or facilitate a discussion for you all in the healthcare recruitment space. And so I'd like to start with Brian. First, we have Brian Tabor, and Brian serves as the president of the Indiana Hospital Association, which represents the interests of approximately 170 Indiana hospitals. Prior to joining IHA in 2008 as vice president, Brian worked in various policy roles for the Indiana General Assembly and in government relations for the Indiana Association of Realtors. He currently serves on several governing boards, including Covering Kids and Families of Indiana, the Indiana Health Information Exchange, the Sycamore School, and the Indiana Fiscal Policy Institute. Thank you for being here. And next we will go to Brock Slabach. Brock joined NRHA in 2008. He has administrative responsibility for all areas of member services, including membership, communications, and meetings and exhibitions. He was a rural hospital administrator for more than 21 years and has served on the board of the National Rural Health Association and the Regional Policy Board of the American Hospital Association. Brock specializes in rural health system development that encompasses population health and the varied payment programs, moving rural providers into value-based purchasing models. Brock, thank you for joining us. And next, I'd like to introduce Carey Goryl. Carey is the CEO of the Association for the Advancement of Provider and Physician Recruitment, also known as AAPPR, and has been there for nearly 5 years. As an accomplished executive for the last 14 years, she's a certified association executive from the American Society of Association Executives and recently served on the board of directors of the Michigan Society of Association Executives. Carey has a master's degree in social work, and she is an active mentor, and speaks regularly on recruitment to retention continuum, as well as association management and leadership topics. Carey, thank you so much for being here. Next, we have Greg Chang. Greg is the Vice President of Provider Services at Everyday Health Group, where he oversees 2 leading healthcare brands, Castle Connolly, Top Doctors, and Healthy Careers. He began his career at Duke University Medical Center, where he oversaw clinical operations and planning for Department of Orthopedic Surgery and catalyzed digital and social marketing at the organization. In 2012, Greg left Duke and founded a private physician network, 4MD, which grew to partner with over 80 of the country's leading medical schools and societies. Greg was chairman and CEO of 4MD before its acquisition by Everyday Health in 2016. Thank you for being here, Greg, and this brings us to Laura Screeney. Laura is the Director of Physician Recruitment for New York Presbyterian. Her department serves as a strategic partner to the NYP medical groups and academic partners, Weill Cornell, and Columbia doctors. As a recognized leader in medical education, research, and clinical care, U.S. News and World Report recently named New York Presbyterian Hospital the #1 hospital in New York for the 20th year in a row, as well as the #4 hospital in the nation. Prior to her role at New York Presbyterian, Laura was responsible for the development and direction of in-house physician recruitment programs for healthcare organizations from coast to coast. HIP Health Plan, Kaiser Permanente, Lifetime Health Medical Group, Atlantic Health System, the Alaska Native Medical Center, the U.S. Army, and Northwell Health. And finally, I'll introduce myself. As I mentioned, I'm the Vice President of Business Development at Weatherby Healthcare. And for those of you who are familiar, you know that CHG is committed to making a difference in the lives of the communities that we serve every day. So we're hopeful for today's discussion that it will provide sort of a domino effect that leads to real solutions for all of us as we face the challenges that are ahead today. So finally, before we get started with our panelists, I just want to share a little bit about the two great companies who are making this discussion possible today, Healthy Careers and CHG. Healthy Careers has served as the leading recruitment and career resource for healthcare providers for almost 30 years, with thousands of healthcare employers and an exclusive network of premier healthcare associations across the United States. So Healthy Careers is really doing great work, bringing together physicians and advanced practice providers with employers looking for top talent. And I know many of you work with CHG or one of our staffing brands, but if you are unfamiliar with CHG, CHG is the largest locum tenens staffing firm in the country and one of the largest overall staffing firms. We provide staffing experience and technology to hospitals, health systems across the country of all shapes and sizes. So both Healthy Careers and CHG care deeply about this topic today, and we wanted to bring this group of experts together to share perspectives. So thank you to all of our panelists for participating in the discussion today. And thank you for everyone in the audience for joining us. We're ready to dive in. So let's start with our first question. And I'm going to direct my first question to Greg. Greg, to help set the foundation for this discussion today, can you please give us some perspective on what your team has observed from a job seeker standpoint, and how job seekers have been affected by COVID-19? And also, if you can shed some light on what your data is telling us about the healthcare provider candidates, how they're responding to the current challenges we're all facing.
Well, first of all, thanks for having us, Cindy, and thanks everyone for joining. So in my role, I oversee Healthy Careers. It's a great business that's been around for about 30 years. And because we work with so many employers, we have at any time 10 to 12,000 jobs up on our site. And as a result of that, we see a lot of macro trends in terms of what job seekers are doing and how they're engaging with new job opportunities. So why don't I just start off a little bit with the raw numbers and then give some insights around that. Organic traffic on our job board is up about 25% year over year. And we were already seeing pretty significant increases in applies, and our main metric, which is applies per every job that's up. So it's interesting, from September to February, we had already seen a 19% year over year increase because of improvements we've made on our site and in marketing. But when you look at the period from April to today, applies per job are actually up 46%. And I think what we're seeing in general, the trends behind this is, one, you have a lot of providers, a lot of physicians who are either dissatisfied with their current situation because they're stressed out. COVID-19 is obviously causing a lot of organizational stress for institutions, which flows down to the providers and causes and exacerbates further physician burnout. So you're seeing a lot of people looking for positions. But it's interesting, when you look at the specialty mix, there are some trends that this is greater in COVID-19 related specialties. So for instance, hospital medicine, applies per job are up 106%, infectious disease 87%, pulmonary and critical care medicine 62%, emergency medicine 46%. So a lot of growth in those specialties. And then in non-COVID related specialties, you're still seeing growth. Family medicine up 37%, derm up 33%. So on the job seeker side, we're seeing increases in job interest across the board, with some specialty trends that are greater than others. In terms of, on the employer side, it's a really interesting dynamic, right? Because most of our partners are having to be very cost conscious and potentially reduce spend, but now might be the best time to hire and market your open positions than ever before, because there's more job seeker traffic and there's actually fewer jobs. We're probably seeing about 20% fewer job postings online. So that means if you post, you're going to have less competition for the same candidates and much more interest for every position. So for those that can take advantage of this sort of unprecedented imbalance between supply and demand, usually we're trying really, really hard to find physicians and get them to come to us, not the other way around. For those people that can take advantage of this situation, I would say it's the best time to try to recruit and the best time to market your positions.
Thank you, Greg. Very, very good insight. I think that, it's not surprising that it's more of a candidates market right now, but I think that brings me to our next question, which I would like to direct at Carey. Sort of, Greg talked a little bit about the employer side, and I know you have pretty broad perspective in your role with AAPPR. So can you tell us a little bit about the survey, the surveys that you guys conduct, and what you're seeing in terms of physician advanced practice recruiters focusing on COVID impact and response? What sort of trends are you seeing coming out of all of the surveying that you guys do?
Sure. So AAPPR represents, we've got about 2,000 in-house physician recruiters, and they represent close to 900 healthcare organizations across the United States. And we do regular research benchmarking every year, but we did a special survey in June trying to find out what the impact of COVID had been on physician and provider recruitment at that time. And surely there is not one story that paints a picture for everybody. But what we saw was that at the height of the pandemic in the spring, close to 40% of healthcare organizations had paused their recruitment efforts entirely, had completely stopped and paused. But 60% kept recruiting. And the ones that tended to pause their efforts tended to be the large and mid-size organizations. The smaller organizations, they kept going. And what we started to see early on, even in May and June, was that organizations were starting to report that the candidate pipeline was increasing. They were getting candidates without much advertising. They had pulled back. Of course, there were no career fairs, there were no conferences to attend, and yet candidates started pouring in, and they also became more responsive. Now, much to what Greg said, we're also seeing the same thing in that healthcare organizations have reduced the number of requisitions. They've reduced the number of positions that they're hiring, really focusing on core areas. And I don't know if this will be surprising to you or not, but AAPPR, we look at what are the top most search specialties every year. And when we looked at and asked during COVID, did that change? And we found out, no, actually the priorities didn't change. It continued to be, much like Greg said, family and internal medicine, gastro, neurology, cardiology, OB, and pulmonary critical care is typically always in the top 10 most sought after searches. We're also starting to see that now that is even becoming even a greater search for some communities out there. So you've got less number of positions, more physicians looking for jobs, willing to relocate, and maybe we'll get a chance to talk about why they're looking to relocate. And at this point now, all organizations have have unpaused their recruitment efforts as of now.
Thank you, Carey. And is there anything that you're seeing right now that's happening as a result of everything you just talked about? Are there any best practices or stories of successes that you can share for those organizations that sort of recognize this early, that had a more favorable market and have sort of taken advantage of that in any way, or used that in their favor?
I think I don't have a specific story off the top of my head. I've heard so many stories. We during this pandemic, we have spent so much of our effort talking to members, hosting roundtables, trying to find out what is happening. So we have a really good sense of what is going on out there. And again, there are no two of the same stories. But what we heard, especially in rural communities, where rural communities prior to COVID, they would say their challenges were location, their sourcing strategies, and nearly overnight, those changed. And physicians who were looking to get out of the big city, maybe wanted to be closer to family. We were also hearing just this sense of physicians got furloughed. They were put on hold. And probably very surprisingly, some physicians were told to stand by. And that gave a lot of time for some physicians to look at, is this the right place? Is this where I need to be? And it's just been an incredible past 7 months for a lot of recruiters and physicians.
Absolutely. And I think that's good. That's an interesting shift that you've noticed. And I know we have Brock here, so I'm curious to get more of his take on that in just a moment. But before we do that, I want to go to Brian. I know Brian, as president of the Indiana Hospital Association, you do have a mix, and some of your sites are fairly or pretty rural. So I don't know if you have anything to add to what Carey said. I want to definitely hear that. But I'd also like to hear from you in terms of your discussions with your members and what you're seeing are the largest shifts as it relates to staffing strategies, in the current environment.
Well, thank you. And again, appreciate being a part of this panel. And thank you for the great work that you do for our members. This is a challenging time, and I think really a particularly challenging moment in this battle with the pandemic. So, I think all of our thoughts are with those frontline healthcare workers right now, and staffing is just generally the number one issue that is being talked about. So I think it'll be very interesting to see what implications that has for public policy. But just one thing that I wanted to note here, and this is really something I think that's developed over the last really even few days, is there is a deepening understanding within the public and within policymakers about the challenges in healthcare staffing. The pandemic in the spring was very much about PPE from the hospital perspective, when I think others were looking in and saying, what are the challenges that hospitals are facing? It was the unknowns of the disease. It was the lack of PPE, and it's very different now. We are better prepared to treat COVID in some ways with respect to new drugs, new techniques. Ventilators are more available, but staffing, and I'm sure those of you that are in the profession are hearing that across the country, is that the available ICU beds and others just can't be fully staffed right now. So with staff that's quarantined. And I think what was hinted at earlier, I think it was Carey talked about it. I've had a number of facilities in rural areas, urban areas, and others saying that in the past, their competition for providers was often each other, others in the healthcare system, but we're clearly seeing some that have the ability to take some time away from the practice now, just step back because of the toll of the pandemic. So it seems like that's just a new kind of angle on competition, or taking away from supply that we've really had. Not something we've seen recently. So I've had a couple of CEOs say that they've lost more staff in the last few months to timeouts essentially from the profession than to other facilities. So that's a really new dynamic. So I do think it kind of causes us all to think about how can we support the workforce that we have and what can you offer when you're recruiting to retain those new entrants into your facility, into your team. So I do think, with respect though to the comment about rural recruitment, we have heard anecdotally that the hospitals have taken some calls, some inquiries even from others who are maybe living in an urban area that are just looking to slow down a bit and maybe return back to where they grew up, or looking for just kind of a different place for their family or for themselves. So I don't know if that trend, how long term that will be, but we certainly have heard some of that.
Thank you for that, Brian, and that definitely makes sense. And we have a couple questions in the chat, and I'd like to just pause here and ask for the panel, whoever wants to answer this one. Are you seeing any physician compensation models impacted as a result of the pandemic? Maybe Laura, do you have you seen any of this? We haven't heard from you yet.
Sure. I mean, we talked a lot about, obviously my health system is in New York City and our surrounding suburbs of New York. So when people talk about putting a pause on recruitment, and some systems didn't, we had no choice but to put a pause on recruitment because New York City was the hub of the pandemic nationwide. So the physician recruitment team at New York Presbyterian and borrowed people from other departments were actually very busy taking physicians from across the country. And our talent acquisition department was doing the same with nurses and CRNAs and PAs and NPs, and bringing them into New York to help us out and take care of our patients, our health system, our city, because there weren't enough people in our city to do that. When you're turning cafeterias and football fields and the great lawn of Central Park and the US Open Tennis Stadium into field hospitals. So basically, yeah, almost everything was on hold, not just recruitment from that perspective. So it's been a little interesting. So our recruitment season almost this year has been delayed. Usually by April, May, and June, we're knee deep in onboarding our physicians that are starting in July, August, and September. This year, people were delayed in starting new jobs. We had residents and fellows calling us that had accepted jobs elsewhere, maybe communities that were not far away from us, that now a private practice pulled back their offer. They couldn't afford to bring somebody else on. We've never had that happen before. Licenses in New York State Department of Health, the licensure bureau, they were all closed. So if you were applying for a New York State license, you were starting your job late. DEAs being changed over to New York State were late as well. So it's almost like been a year, in some ways very fast, but that piece of it almost slow motion. So a lot of our new hires have now are still starting actually through the end of the year, which is very interesting. So we're still in the mode that we're making some offers. Have offers changed from a compensation perspective? I don't think so. I mean, we didn't finish the pandemic and say, let's totally regroup our comp structure. We're kind of trying to get through and take a look at what positions do we need to fill, and which ones really, when you're back to business as usual, because our ambulatory sites had all been closed. They're back up to, actually, we just had a New York Presbyterian whole town hall, and we're back up to 90% of our ambulatory visits. Surge is back up, getting back up. We're still not up to 100% in our market. So it's really taken our year and our recruitment cycle and almost tossed it on its ear from that perspective.
Sure. And I'm going to follow that up, Laura, with another question for you. As a leader in the middle of the epicenter of the pandemic, when it arrived on our doorstep, and also one of the most prominent New York health systems, how do you balance, and how does your leadership team, how do you balance the financial crisis that we all have seen impacting with staffing, the best talent in the industry, and providing excellent care for your patients? It seems like sometimes those things are in conflict. How are you all balancing that?
Absolutely, yeah, and no doubt. I mean, all eyes were on us, and as Carey knows, a lot of people in our industry through AAPPR were just sending me random texts because they were in geographic areas that weren't dealing with it yet, but everybody knew, oh my gosh, you're going through it now, and it may be coming, and the support we got was incredible. But yeah, from a financial perspective, we were flying people in, took advantage of some of the airlines that gave free flights, but a lot of those airlines didn't fly into markets where we needed them to fly into. Never in my entire life, I'm a born and raised New Yorker, there were weekends where JFK and LaGuardia were closed. It still baffles my mind. We had to put people up, we had to fly people in, we had to pay for additional staff, we had to pay for additional coverage. All of our AMS, there were no AM surgeries going on, all of our ambulatory offices were closed. We definitely did a lot of virtual visits and we had to flip on our ear that quickly, but we all know there were a lot of people that were not walking into them. Emergency room volumes were down 65%. So we know a lot of people were not receiving the care they should. So yeah, now we are really taking a heavy duty look at our finances. This budget season is like no other. Usually our budgets would be in by now, but again, everything else is delayed. I see Brock smiling. So yeah, we're still knee deep in budget season and we are reevaluating our positions. We're also looking at our system as a whole because we've been the #1 hospital in New York for 20 years. So we're not going to compromise care. We do recruit the best of the best from that perspective, but we're also taking a look at our internal talent. And not that you could take an OBGYN and flip them over to go work in an ICU, but take a look at our talent as a whole. We've got close to 50,000 employees, we're like 48,000 employees. We're taking a look at all of our positions and do we take a look at recruiting from the outside or we have so much incredible talent within that let's really take a deep look at there are people that have been cross-trained, there are people that have other interests, there are people that have skill sets that really can seriously take a look at those jobs. I know most health systems try to post jobs internally before they go outside, but we all know as recruiters, it's a delicate balance. And again, I'm talking a little more on the non-physician side, but how do we take a look at, let's take the staff that's very talented, that's been extremely dedicated and loyal to our health system in our city, especially during a pandemic, and let's make sure we're able to keep them whole and keep them within our enterprise. And let's make sure if we don't have a need at one site, can we put them at one of our other sites? Can we put them in another department? Because our senior leadership has made a commitment that they don't want to go through a layoff. And it's no secret that health systems have spent, in New York City overall, has spent a lot of money, a lot more money than they ever dreamed on taking care of the city of New York.
Mm-hmm. Excellent. And Laura, are you all working on plans right now for a second wave and a surge? And if so, how are you thinking about that from a staffing perspective?
Yeah, we're looking at it very closely. We actually just had a meeting yesterday. We really took a look, and I think overall, so as a lot of you, no surprise, my team compromised. We were the Physician Recruitment Command Center, and we borrowed a lot of people from other departments because there's no way the four of us could have handled it. But we put processes and systems into place that actually other parts of our organization took a look at and adapted our policies and procedures. A lot of it was stuff that we do in physician recruitment and provider recruitment anyway, but it almost took it and put it on steroids. How quickly can you get somebody in? How quickly can you get somebody credentialed and privileged? We were lucky that New York State took a look and said, okay, and if you have a license in any one of the 50 US states or 2 territories, you can come to New York. That doesn't exist right now. So if we go into a surge, that's something that, the state would have to take a look at again. The Greater New York Hospital Association, which is all the hospitals in New York, kind of gathered together and would speak to New York State leadership with one voice. So it wasn't, New York Presbyterian going to Albany and Mount Sinai going to Albany and NYU. Our leadership would talk as one voice and talk to Albany and say, this is really kind of what we need. So we've reevaluated the systems that we put into place during our first phase. We're praying, I'm knocking on wood a lot. We're praying that we don't see what the rest of the country is seeing right now. As a city and as a health system, I will say walking around New York City, everybody's walking around wearing masks. You don't see anybody on the subway. You don't see them on a train. You don't see them on a bus. We're being very, very careful. We've had pockets in certain neighborhoods where we started to see some spikes around certain holidays. So those areas would say, okay, restaurants are not fully closing again, but it's total outdoor dining, not the 25% in-house. So we're really trying to take a look at how do we prevent the surge. hoping it's not as bad as it was. I think we're probably more prepared in the long run. And then let's take a look at our staffing overall. Right now, our numbers have gone up, not huge. I know the media kind of talks about it. They're up, they're up, they're up. Our cases in the ICU and patients that are intubated are not spiking. We do have, the numbers are going up with our inpatients in the hospital, but not in the ICUs. So if we do have to additionally staff, we're taking a look at what specialties do we really need. Is it going to be the intensivist or is it going to be the hospitalist? So it's those pieces that we need to take a look at really, and manage what we have.
Thank you
But
for that,
please no.
Laura. That's right. So Brock, I'd like to hear from you. And before I ask my question, I just want to give you a chance to sort of respond to what I think Carey and Brian shared about sort of that shift and that more open-mindedness that we're seeing in terms of the candidate pool to move to or relocate to more rural areas. Do you feel like you know, your members are taking advantage of this situation yet? Have they been able to sort of raise their head up and recognize that is happening? And so just curious to get your perspective on that.
Well, thank you, Cindy. And like everyone else, I'm delighted to be on the presentation this afternoon to talk about this important topic because it's space, staff, and stuff in terms of how we deal with hospitals. And if we don't have the staff, it doesn't matter how many beds we have. It doesn't matter how much stuff we have. That's the critical factor. I will say, in answer to your question, to start off, Cindy, we're looking at 18 states, most all of them rural, have 10% COVID hospitalizations in their beds right now. That is looking at surge capacity at this point. We're seeing transfers of being delayed of myocardial infarctions from rural hospitals, strokes of 4 to 6 to 10 hours to get to a tertiary referral source because they're full because of COVID. These are some really impactful problems that our hospitals in these 18 states are dealing with presently. And it is all hands on deck in terms of addressing. So when I go back then to March, and I am getting to the answer to your question, Cindy, when I go back to March, we began the pandemic and we saw in April the serious situation that Laura just described so capably in New York, but we didn't see that in the rest of the country. And our hospitals were hemorrhaging cash because we closed all of our elective and non-emergent services, and the hallways were empty. And in that climate, it's hard for a hospital administrator or a physician recruiter to say, let's go out and just start recruiting people, because they were really nervous about how they're going to keep their doors open, yet alone recruiting new folks. Right. So I think, to answer your question now, Cindy, I think that because of all of the changes and the amplitudes and dissensions of energy, I think that there's been a lot of apprehension to enter into recruitment. I've already made a note that I'd like to get a couple of the panelists today to do a webinar for our members, because I think that they don't understand that there is a supply available, that some of the more opportune moments now could take advantage of to fulfill some of their recruitment strategies. And I will take a moment to just mention something that's extraneous to the pandemic to answer the question on physician contracting. And that is that obviously a lot of providers in rural areas have contracts that will last at least a year. So they'll be trying to figure out how to get through that period. But what we're looking ahead towards is the physician fee schedule that has yet to be finalized this year. And we're looking at 9% to 7% cuts to surgical specialties in terms of the physician fee schedule. And these could have equally serious impacts on the ability for at least our rural members to be able to maintain important access to care, for example, general surgery and other important services in those locations. So, so I think that this is kind of the holistic way that I'm looking at this, and really some interesting examples being shared today. So thank you.
Yeah, thank you for that perspective, Brock. And maybe you can also shed a little light for us on, your outlook on telemedicine. Obviously, you guys have in rural health, you've sort of flipped upside down in terms of the adoption of telemedicine during the pandemic. And I know there were a lot of challenges associated with that, both from a patient adoption perspective, but also just how to get everything in place to be able to offer that. So talk to us a little bit about sort of where you've been and where you see this heading. And I know a lot of it is dependent on policy, but I'm still curious to hear your perspective.
Well, in that era that I told you about, now seeming ages ago, in March of this year, when the public health emergency was declared, the Congress passed legislation that enabled clinics in rural communities, rural health clinics, and federally qualified health centers to become distant site providers. This was important to be able to allow them to provide telehealth services to the communities that they serve. So prior to COVID, about 0.2% in our rural communities of E&M services were provided through telehealth. And after the public health emergency went into effect, we saw percentages in many of our locations at 80% of the services that they've been providing on evaluation and management services went to about 80%. So almost overnight, we went from less than 1% to 80% telehealth visits. This is leveled out after the reopening of our clinics and hospitals to services following the initial influx. This is now at about 12% of volume is being conducted through telehealth. These volumes are very important to our providers, especially as we look ahead to this fall and winter, and we're already into a surge that's beyond what we expected this early. I think that many hospitals around the country, I know here in the Kansas City, Missouri area, they're looking at restricting and closing elective and non-emergent services because hospitals in this region are filling up. And now telehealth may become once again really critical to their ability to provide important and necessary services to the communities that they serve. So we see this as integral to the strategic plans of our members, and making sure that they have the tools necessary to one, sustain themselves in terms of their business model, and two, ensuring that their communities are well served with access to care.
Well, that's really interesting how that's shifted, and just thinking about those surges that you mentioned. How are you all working to create adoption around that, right? And I think in rural areas it can be particularly challenging because of just internet access and a lot of different variables there. So do you have any best practices to share with the audience around how to make your patients more comfortable with this idea?
Yeah, it's really amazing. I'll make a reference to a resource that I think that many of our members have found useful. The American Heart Association has the Don't Die of Doubt campaign, which tries to reassure the community to the safety of accessing services in the clinics and hospitals. I think in this surge, during the surge period, I think that patients need to be aware, and I know that many of them are finding out, particularly within emergencies, that it's not just COVID infected patients that are impacted by the surging of patients that we're seeing. As I said, when you have a heart attack or a stroke and you're finding it difficult to be transferred for definitive care in an urban setting, you may have to wait. And of course, that means either increased morbidity and God forbid, mortality as a result of that delay. And so I think that the public is becoming aware of that reality. And going back to what Laura said just a second ago, I mean, I can't go very far into any presentation today without reminding people, especially in the rural areas, resistant to wearing face coverings, that it's face coverings, avoid large gatherings, making sure that you get that flu vaccine, and of course, staying at home when you're sick. And we've got to find a way to mitigate the spread of this because we don't have enough resources beyond that 10% level I talked about a second ago. We don't have the resources to go much beyond that in terms of definitive care for patients. And then we get into crisis standards of care, which completely removes a lot of the assurances that we as a public have in this country of being able to get attention that we think that we need and should deserve.
I think that's so important, and thank you for sharing that, because there are a lot of opinions out there on that topic, and so I appreciate you just sharing your very valuable perspective on that. And I'd like to turn to Brian now, similarly, to get your perspective on telehealth, and from your seat, how to what extent do you foresee health systems really leaning in on this going forward? We mentioned, policy, certainly a question mark right now, but if we're looking at surges across the country again, and if we're trying to learn from what we experienced in March and April, how do you see the presence of telehealth as we look toward, long-term strategy within health systems?
It's a very good question. I don't think we know exactly what that percentage is going to level out at. So if we look at it from, how much is telehealth going to replace those in-person visits? I think that's a tough thing for a health system to figure out when they're looking at staffing. What does that future look like? I think Brock talked about it going from 1% to 80 and then back down to 12. Talk about being whipsawed. That's huge. And we're in one of those states that Brock talked about being really on the edge right now. Not to jump right back into COVID, but I think that's where we may see. Our governor will make some announcements today. Many hospitals in the state are already having to reschedule procedures because of the hospitalizations being up. They're up 143% since October 1st as of yesterday. So, access may kind of revert back to telehealth. For some, that could be the preferred method for some visits that had returned to an in-person basis. So I think we're going to see back and forth here throughout COVID with ups and downs. So long term, though, I think it's going to increase. I think that telehealth, it felt like from an adoption standpoint, had kind of leveled out. And I think the change here is that it's been introduced to a new audience, whether or not they have gone back in person. They may be going back in person, but in many cases we're hearing they're still supplementing that with the telehealth visit. So I think it may not be exponential, but I think the growth is going to continue because a lot of people that may not have been willing to try it before the pandemic tried it and found that they were comfortable with it. But what we've also heard is they're not comfortable with it necessarily being the only resource. It's preferred by many physicians, and I think by patients, to be, again, a supplement to that face-to-face visit. From a regulatory perspective, that's one of the things that's been holding telehealth back. And I think treatment by the payers of telehealth as well. I think the genie is out of the bottle in some respects. Some of the regulations that the federal government relaxed, I think there'll be legislative support both in the Congress and here at the state level in Indiana, telehealth legislation to ensure that it does have an environment in which it can continue to flourish. That's at the top of the list for lawmakers. So I think if we could pull COVID out of it and all the ups and downs of that roller coaster, I think post-COVID, we will see a continued increase in telehealth. I think it's just hard to say how much it will be. I think Brock's observation about going from 1% to 12%, that's still a huge jump. And so that's where we may find ourselves next year, let's say at this time, when hopefully the vaccine and therapeutics have put COVID mostly behind us.
Thank you, Brian. And I would have to think, being much further removed than you are today and Brock is, but I would have to think there have been significant learnings too in that greater entree into telehealth that we can take with us into the future, no matter what that volume looks like, which I agree signs point to continuing to, I guess, lean in that area. So Carey, I'd like to shift somewhat as we're talking about telehealth and shift back to the staffing piece and sort of talk a little bit about what we've learned and the virtual recruitment environment and how you foresee similarly staffing to evolve as a result of all of our learnings this year.
Oh, okay. Well,
I switched it up on you.
You did? Yeah, that's okay. But I was listening to Brock and Brian talk about telehealth, and I just thinking, well, right now we're doing telehiring. And that's been probably the most significant change when everything was done in person. Even along the process, one of the stories I heard was, in the hiring process of a candidate, there are a number of sign-offs that need to happen. And the process was that the sign-off had to be a physical signature by each person. And so you'd have the recruitment professional walking from department to building to department, getting these sign-offs. And now all days of a lengthy process has now evaporated into a 10-minute DocuSign. And really, that technology was always there to begin with, but much like telemedicine, there was resistance, there was unsurety around, could we do this in a virtual environment? And the answer is a resounding yes. While there was a lull in the surge over the summer, what a lot of recruitment professionals did was double down on virtual interviewing, virtual site visits, virtual job offers, even getting into virtual onboarding. And the whole process has been done similar to this and become much more streamlined, so much so that physician recruiters are saying that the amount of time it takes to fill a position, generally, it's going to be around, I'm going to give you a ballpark range, around 120, 160 days. Really depends on a lot of factors, the specialty, the area. But looking at how that is decreasing in this environment, because so much of this can be done virtual, we don't have to worry about candidate schedules. And people were being really innovative. Real estate agents have long enough done virtual house tours. Well, let's just take that same technology and do virtual tours of the ER or of the clinic. And be able to show candidates what it looks like from that side. It doesn't completely replace it. I think much like in telemedicine, people will eventually prefer to do things in person. But what I'm hearing is that first round interviews being done virtually is probably here to stay.
Definitely. It sounds like there are a lot of learnings this year that will have a big impact long-term from a time and financial standpoint. So maybe Laura, did you experience any of that firsthand, any of sort of silver linings of COVID of how to maybe do your job and help your team do their jobs, just more efficiently?
Absolutely. Yeah. I mean, it's, speaking of Carey, we were a little obviously late to the game with interviewing people for full-time jobs because we were busy with COVID. But after the fact, yeah, I mean, virtual interviews. I work for a large academic health health system. Our two medical colleges are Columbia and Cornell. So talk about, the ivory tower, old school, and to try to take a chair and say, you know what? No, you're not going to meet the doc in person. You're going to do something called Zoom. And now they're getting used to it. So it really does make it a lot easier, especially in a health system like ours, where somebody may be working in one of our community hospitals, but they also have to meet the department at the academic facility, which if any of you know New York City, it's not easy to get from Washington Heights, where, Columbia University Medical Center is, up to, the Hudson Valley. It may not be that many miles, but in traffic, it's not easy to do that with a site visit. So now, yeah, there are some things that we probably will juggle and say, you know what? We probably want you to go see the facility and the community you're going to live in, because you probably don't know much about it. I know everybody thinks, everybody comes to New York and the only thing they know is Times Square. None of our hospitals are in Times Square. And people don't live in Times Square, but how do you, now we could probably take a look and say, you really need to meet the leadership there, but you're not going to be there every day. So we could probably do that piece of it virtual, which makes it a lot easier when you're dealing with a department chair or a department chief or a scientist that's doing research on a regular basis. So I think we'll be able to take some of that stuff and apply it. We wish we could take the onboarding credentialing piece and truncate it the way we did. We took people and we credentialed them. We gave them a credentialing packet at 8 o'clock in the morning, and they were going to the board of trustees for privileges, emergency privileges, by 9 o'clock that night in the same day. I know, I see Brock going, oh, I mean, it was nuts. It's obviously not going to happen because, you know, Joint Commission let us truncate the processes, but does it make us take a look at those processes and say, okay, what areas can we truncate these pieces in, and how can we make it easier? How can we make all of these processes easier? How can we take even some of the politics out of it? You know, Carey said, you know, the physician recruitment professional that ran around campus from building to building to building to get signatures. We had a lot of that stuff as well. Invoices, I used to have to sign off on our invoices, and then we had to scan them in and get them all over to Fine. And guess what? We're not doing that now. You know, our corporate headquarters is it's still skeleton staff because we're open concept, but yeah, how do we take a look at lessons learned? And then, you know, when Brock talked about televisits, I take a look at ours. My 84-year-old father did his first telemedicine visit during COVID. You could just imagine what that was like. My sister was on the front stoop trying to coach him through the front door on literally how to, you know, how to use his. My father has an iPhone. He can use it. It's great, but he's not usually pulling up FaceTime to talk to the grandkids. But again, how do we take those and how do we modify and adjust and maybe find a happy medium for any of those processes and help to streamline anything that we do? And anything, I think any part of it. How do we streamline it?
Right. And I think that sounds like a great takeaway for the audience. If they don't take anything else away from this webinar today, that we can use some of the learnings from 2020 to just get better. And there have been, I think, a lot of learnings this year, but I think the shift to a more virtual environment is certainly an area where we can figure out how to gain efficiencies. And I feel like Greg should have some interesting perspective on this in his role as well. So Greg, I want to give you a chance to just maybe share your perspective on and how you're seeing all of this play out.
Yeah, thanks, Cindy. You know, at Healthy Careers, you know, we work with approximately 5,000 customers a year, ranging from, you know, your mom and pop small practices up to your, you know, publicly traded health systems. So we do get to see sort of the trends and also the cutting edge. I would just echo what Laura and Carey have said about how the recruitment process is becoming more and more digitized. And I do agree that over time, while it will swing back a little bit because recruitment is a human-centered activity, there will still be a digital component to it. I will add that more things early in the recruitment process, we've seen also switch to digital. So, you know, we hold about 15 to 20 live events per year with specialty society partners. We had to transition all of them to digital. And for those that were able to take advantage of the opportunity that transitions present and do things in a new way and seize upon those opportunities, that transition was actually very fruitful. On average, our digital events brought in 30 to 40% more attendees. So a lot easier to reach more people, less travel costs associated with doing these events because you can do it from the comfort of your home or your desk. And then we've actually seen more and more of our customers shift to do employer-specific virtual events as well. We did an event with one of our multi-state health system customers a few weeks ago. And from one event, they had 700 physicians sign up and we're able to have 1,000 recruiter physician chats. Wow. So, you know, I think we're going to see more of that on the front end of the recruitment process as well. So, you know, I think in some, there's going to be more shift to digital in the short term and you'll have a swing back of the pendulum, but a digital component to recruitment, I think, is here to stay.
Definitely. I just want to make one comment about that, and then I want to go to Carey, because when you say 30 to 40% more attendees and one event bringing in 710 attendees, I think that's an important point to highlight, that those numbers would speak to the fact that this is a favorable way to do this for candidates. And I don't know if you're hearing any other feedback from candidates about some of the events that you've hosted, Greg, if there's any additional comment needed there.
Yeah, candidates really preferred it. You know, physicians are trained to do a very specific thing, and the job search process is not always a comfortable process for them, especially early to mid-careerists. And so we've actually been surprised at the uptake and the adoption on the candidate side of these virtual events. And I think we attribute it to the fact that it removes some of the awkwardness and also allows you to kind of put yourself out there without, having to put on the whole shirt and tie, go to an event, hand out resumes and cards. It's just an easier, lower friction way for them to engage with potential opportunities.
That's fantastic. Thank you for sharing that, Greg. And Carey, I know you had a comment about that as well.
Yeah, I just wanted to echo Greg's comment and emphasize that taking on a new job is it's in the top 10 most stressful things that a human can experience. And so despite the virtual and digitization of the process, the human to human interaction, even though it's virtual, is so critical that something like an applicant tracking system, a computer making it automatic or robotic is not the future in this. Simply that we're using technology to continue to make those human-to-human interactions.
Absolutely.
Yeah, and
that's
Cindy,
great.
let me jump in for a second. I will say just recently it's been interesting because I think a little bit of it that gets lost in the process is the physician recruiter is having more of those virtual interactions with the candidates, but not necessarily on camera. A lot of it is more behind the scenes. And Carey brought up applicant tracking systems. Some of it does become very depersonalized. Just recently, my staff is finding we've actually been doing a little more just quick FaceTimes with our candidates. If they want to talk to us at night about something, not a scheduled Zoom, not a big deal, but we'll say, hey, you have time tonight, we'll do a FaceTime. And we're finding they're liking that a little better because they're missing a little bit of the personal connection. And they tend to develop that a lot of times with the recruiter. Greg talks about the nervousness and, it is awkward if somebody is not, it is like putting on here's me and I'm trying to impress you, please give me this job. And everybody's not comfortable with that. So we're finding some of that is helping a little bit. We didn't plan it. We just started doing it, and it's been very, very well received. So another little tip that may come up, I think that may help, again, ease the tension, because I think the physician recruitment professional does help make that person comfortable. And then the candidate's able to show them true selves when they meet with the department chairs and the chiefs and the leaders. But they almost become buddies with the physician recruitment professional and somebody that they learn to grow and trust. And it's not always easy to develop that trust when you've seen the person's picture on LinkedIn, but you haven't had that interaction. You don't even know what their voice sounds like.
Absolutely. Yeah, that definitely takes time. It's nice to see people adapting to this way of life so quickly and easily, though, because I do think there's a large element of this that will be here to stay. And I know we wanted to take our last question around 1:15, so I do want to shift right now just to something that's going to be critically important, in the coming months. It's always important, but I think even more so now, which is provider burnout and provider wellness. And I know it's a really concerning topic right now with some of the states realizing surges and just a lot of uncertainty in general. And we've talked about that a little bit, but I'd like to go to Carey first and just, get your perspective on how do we learn from this year as it relates to burnout and wellness? And, are there any best practices that you're seeing within your organization that, our audience might be able to take with them as they continue to focus on this?
Yeah, so just to sort of level set, physician burnout was already at an all-time high. Physician suicide, a significant issue that healthcare must grapple with. Interestingly, we were starting to notice not that turnover is a direct connection to burnout, but burnout can be a factor in turnover. We were starting to see that turnover in our latest benchmarking was at a 5-year low for both physicians and advanced practice providers. And I think we're all going to be a bit curious around what that data is going to show next year at this time. One of the things that we are encouraging healthcare organizations to do around retention and around burnout is having those conversations. We call them stay interviews We have a guide. I'm happy to share it with the audience or with CHG, and you can share with the audience. But it's a guide that helps physicians connect with why they're doing the work, why they love working at the organization, the patients they serve. Really, it's a grounding exercise, and being able to check in with people now. If you haven't checked in with your staff, check in with them now. And if you have done this, you check in with them at whatever interval feels right, once a year, twice a year, and do these sort of stay interview questions to help identify are there issues? Because Susan, I'm sorry, Laura, you know this better than I do, that as soon as a physician is feeling sort of out of sorts or doesn't feel like they're getting the help they need, a lot of times the first person that they call is the physician recruitment professional that they first met, to say, look, this is what I thought it was going to be, and this is not happening, help me. And physician recruitment professionals fill that void, and many times when they don't know where else to turn, they often turn to people like Laura.
You become their buddy for life.
Well, Laura, I think that's a great segue, because, you know, when we last spoke, you talked a lot about just what you went through personally and your team went through with just the stress and the anxiety and the uncertainty of what was happening in your community. So do you have anything that you can share with the audience today on how you helped not only your providers, but your team and the people around you who were all feeling the effects of really the stressors of the situation?
Absolutely. It was very interesting because, again, I was running a command center that a couple of people were my team on a day-to-day basis. Some people were people that I, dealt with people in strategy that had never done physician recruitment before, service line leaders that I really didn't know very well and now become really, really good friends with. But how did we handle the stresses of it? Because a lot of us were dealing with, you'd talk to a colleague on the phone, couldn't reach them the next day. You'd find out they were in the ICU. You're talking to people on the phone, you're on a Zoom, somebody drops off. A lot of us had family members in the hospital and we're going through it. So your family member, we had to drop my mother off at the hospital door and drop her off and let her go in because you couldn't go in with your family members. So it really hits home. And then, one of our physicians committed suicide, which really, a lot of people heard about. So how did you handle the physicians that were there, the staff that was there, the frontline staff that was there? We had physicians in from other organizations that were working with us that were not near their families. They were going back to a hotel room by themselves at night. We had physicians coming in from UCSF and Cleveland Clinic and Intermountain Healthcare, Arkansas Hospital that came in and helped us, nurses, doctors. So talking about, we actually had quiet rooms that we set up. We set up our own, we had to set up daycare centers on campus because that was stuff that was very stressful to people. We took advantage, we took the new vending machines that now have fresh food in it every day because all the restaurants locally were closed. And then people couldn't even on the way home, the grocery stores were closed. They couldn't even pick up food on the way home, and talk about added stress and work-life balance. I just need to pick up groceries on the way home to give my family dinner. So we were providing stuff like that. So what support services could we give our staff that they could be at their best and take care of themselves? Because if you're not taking care of yourself, you're not doing a good job for anybody, and we all know that. From our team perspective, again, we were not on the front lines, but I know Rob was texting me recently. I tried to do some goofy, upbeat stuff every morning with our team, and one of my favorite, and maybe you want to share it with the group after, some of it was Jimmy Fallon and the Roots videos that they did, and our favorite one was when they did the children's instruments with Pressure, the song Under Pressure. And when we were all feeling really stressed at a staff meeting, we would actually put that video on first, and we would all kind of listen to it for a couple of minutes, and then we would go on with the seriousness of what we were working with. It may sound silly, but we laughed. We said we have a theme song. The only thing we were missing was a mascot. But Carey's right. Physician burnout, provider wellness of all of us is frontline and center. And even those of us that aren't in the hospital are now sitting at home. And I don't know about you, but you're sitting in the same chair for 8 hours, 10 hours, 12 hours during COVID, 20 hours. And you'd go to stand up and you couldn't even stand. So how are we taking care of ourselves? How are we adapting? We have wellness coaches in our enterprise. Now, we used to go meet with them. Now we're doing virtual visits with them. We're doing some more challenges amongst the staff to try to get people, how are you active? How do you share that? I just did my first virtual corporate challenge one night last week. It was a 5K, and some guy's voice as I was doing it in the neighborhood, instead of running through Central Park and people cheering, every time I hit a mile, I now decided I want a half mile. They go, yay, mile number 1. And you're like, okay, yay, mile number 2. But how do we do those things to make sure that our staff are taking care of themselves overall, and not just the physicians as well, but everybody and all of us.
I love that. And I think a couple things that you said in there is, you know, encouraging people to put their own mask on first and creating programs that allow them to do that. But also,
you a flight attendant in a previous life, right? You put yours on first and then the person next to you.
No, just a mom. So a lot of people tell me that as a mother that I need to do that. So, yeah. But then also just the levity, right? Because the situation is so intense for so many hours a day, and figuring out how to really connect with people to help each other get through that. I love that.
Yeah. And I don't know if the rest of your communities are doing it. We had the 7 o'clock hour in New York City, if everybody remembers. That started off when one of the local fire departments actually went to our hospital downtown Manhattan, and the fire department stood in front of our hospital, and they actually applauded all of our staff, and they played music, and the fire truck was right there. And FDNY started doing that around the hospitals, and then people started hanging out their windows at 7 o'clock to bang the pots and pans and stuff, and it was like thanking the heroes. Again, it may sound goofy. People then started playing music. So you'd hear, so if it was an Italian neighborhood, they'd start playing like Frank Sinatra, you know. I mean, it was interesting how people took these things. And again, how do we miss that human connection? And people really needed that. So I think harder to do, Brock, in a rural market, you know, if somebody on a farm tries to, you know, ring a bell, I don't know if somebody's going to hear them at the next farm, but how can you do something virtually that still brings that community together? Because if there's a time that we all really need each other, it's during a time like this. It's during a time of crisis.
Absolutely. Very well said, Laura. Thank you. So we do have just over 15 minutes left, and I did want to ask a question as we all we have the election behind us now, and we're looking forward toward 2021. And for the panel, I don't know who wants to answer this first, but what are the topics and policies that you're watching most closely now as we look forward to a new having a new administration come in January? What is everybody watching, and you know, and why are you watching it closely?
I can go first, and you know, I think the first thing I would say is, especially with where we are right now in Indiana and neighboring states, and really just the region right now in the battle against COVID, I think hoping for a smooth transition that does not disrupt any of the work that's being done to address the pandemic. So we're starting to see the delivery with the emergency use authorization of Eli Lilly's new therapeutic. These are really, you know, positive signs that drug, once it's in circulation and we can increase the capacity of production, it's going to help keep people out of the hospital, which is a huge strain now. We know that their vaccine with some promising results. Some vaccine could be coming as early as this month. It's going to take a long time to get it into enough arms to, you know, develop the kind of immunity we need broadly. But there are some signs we've got to kind of buckle in. So I think, you know, one of the things we'll just be really watching is to make sure that, you know, a transition between administrations, especially one that is quite frankly fraught with the contention that contentiousness we're seeing right now about the transition itself. And that is a concern because regardless of what this final outcome is, we need to make sure that all of that work is not disrupted, because it's critical. Also, the outcome, and this is partly a legal question, but there would also be a political policy response, would be the Affordable Care Act. And we could talk about lots of different things, coverage and what that means to individuals. We have a bipartisan program here, the Healthy Indiana plan that actually Vice President Pence expanded. We certainly would be concerned if we lost that opportunity for coverage. It's grown tremendously as people have been hit with the economic disruption of COVID. They're turning to that for healthcare coverage, so that's important. But apart from what that means for patients, having that coverage, just the Affordable Care Act is so comprehensive, the concept of it completely going away. There are some things that we'd love to see fixed in the ACA from the hospital community, at least speaking on behalf of Indiana hospitals. But the disruption of that uncertainty would just be so difficult for the industry to take. Now, it sounds like based on the oral arguments, maybe that's less of a possibility that that's going to happen. So I think what all of those things mean is we just need some certainty. We just need some consistent messaging, some consistent guidance on various things from the federal government over the next few months, because our frontline workers have all that they can handle right now, and they're tired after months and months. So I think if there's anybody that's kind of tired of the politics out there, it's got to be those frontline healthcare workers who are just saying, I don't care what party it is, just do everything you can to help support the work that we're doing. So that's what we're hoping for, just a little bit, some clarity, consistency, and steady support for the industry.
I think that's great. Very well said, Brian. Thank you. Brock, did you have something you wanted to add there?
Oh, thanks, Cindy. Yeah, Brian did a great job. I think the only thing I would add that we're certainly looking for, and what President-elect Biden is going to be featuring, is leaning on Congress to pass a stimulus package. We're hopeful that that's going to be done before the end of the year. Senate Leader McConnell has indicated that that's what he's looking to try to do. So we're keeping our fingers crossed on that. We went through about we went through several rounds of CARES funding. So we need that next bit to help our providers get through this now fall and winter surge that we're going to be seeing. The other thing I would only point is that I was really encouraged, and I know our professionals were, about the creation of the COVID task force that President-elect Biden has enacted. He's put Doctors Kessler and Murthy as the co-chairs, and their focus will be embracing science. And then the other part of their big push will be, and I guess we'll have to, as public health professionals, be participating in this, is pushing mask wearing as a patriotic act. And so I think the equivalency of those two things might be really helpful going forward.
Absolutely. Thank you for that, Brock. And I did see that this week, and I was also very encouraged by that as well. Carey, anything to add from your perspective?
Yeah, so one other thing to add to what Brian and Brock have already said is around the issue of immigration. We're always looking at the policies that are enacted, and even just the messages that the administration is sending around immigration. There are enough communities that rely on international medical graduates. And so with that, it also comes to, we're looking at equity, diversity, and inclusion, and that our communities are supportive of hiring diverse candidates who may not look or sound like the community that they serve, or more importantly, that they do look like and sound like the community that they serve. And I think that's going to be really important moving forward, and we're going to be paying attention to that.
Fantastic.
If I could just jump in, I want to say I'm really glad that Carey made that point. It's an excellent point. And I do hope with what I said earlier is that the politics around that issue in terms of immigration, what it means for our healthcare system specifically. Again, we're seeing so much media coverage right now about the healthcare staffing challenges that hospitals had. I mean, you had staffing challenges, Laura talked about them. I think most of the media coverage was about PPE. But I think now with what we're seeing with this second wave, whatever you want to call it, there is being a light shown on the scarcity that we already had. And hopefully that will lead to a bipartisan agreement that we have to do everything we can to make sure that we have an adequate healthcare workforce supply. I hope that people will learn the lesson in terms of what's kind of coming to light right now.
Absolutely. I think that's important point. And Laura, I think you were going to say something.
Yeah, I mean, and my fellow panelists, again, every topic I find myself nodding my head like, absolutely, it's so important to what we do. The other piece that this all leads to is in bringing healthcare injustice to light. That's something, as you take a look at the COVID numbers, you take a look at your underserved and your underserved communities, whether it's the underserved communities in New York City or in the rural hospital that's multiple hours away from the tertiary facility. Take a look at how the poor populations, the immigrant populations, how COVID hit them harder. We were very blessed that a entrepreneur in New York City, Ray Dalio, I don't know if you saw the Bloomberg report, gave us $50 million to found the Dalio Center for Healthcare and Justice that New York Presbyterian has been entrusted with. And we do have a group of folks that now are taking a look at our neighborhoods, taking a look at how healthcare hits our communities. I mean, talk about a public health initiative that's been long overdue. And I think the COVID numbers have really brought these very important healthcare issues to light. So as Brian said, it doesn't matter what side of the aisle you sit on. These are all issues that are important to everybody.
Absolutely. Yeah, thank you for sharing that, Laura. Well, I think we've heard adaptation is sort of the word of the day today, and there are, of course, a lot of sort of silver linings that will come of this experience that we've all had this year and 2020, and a lot of learnings. On that topic, are there any resources that you all might recommend for our audience as support as we all maneuver through the challenges that lie ahead? Carey, I think you had mentioned a resource earlier. Do you want to just give us a quick overview of exactly what that is?
Well, one of the resources I mentioned was our state interview guide that would guide any organization that wanted to do those types of interviews. That is on our website, and happy to share it. I also referenced the survey that we did on COVID's impact on recruitment earlier this summer. That's also freely available on our website. And because so much of what we do in healthcare is in part driven by data and metrics, I would, of course, reference people to our annual benchmarking data on physician and advanced practice provider recruitment if they are not already familiar with that.
Wonderful. Thank you, Carey.
Mm-hmm.
Anything else? Okay, well, Greg, were you going to add in there?
Yeah, I was going to say Healthy Careers, we put out content on a regular basis for all of our customers and just physician recruiters in general that talks about broader trends and things that we're seeing. So I can send the resource, a link to that to you, Cindy, so that we can send it out to a larger audience. But some of the numbers that we talked about with a lot of increased seeker interest, specialty specific trends, we share that information. So I'd be happy to pass it along.
That's fantastic, Greg. Thank you for doing that. We'll include that when we send out the recording. So first of all, I just want to say thank you so much to our panelists. This was super insightful, and really appreciate you all taking the time to just share some of your knowledge and expertise and perspective on everything that's happening right now. As a reminder for our audience, we will be sending out the recording shortly after, and we will include a survey in there. We want to hear your feedback on what's most valuable if we, for future webinars, what's important and what would you like to hear about. And lastly, thank you for taking the time to join this discussion. I know there's so much more to explore on all of these topics, but hopefully we left you with some ideas and some information to make a positive impact on your recruiting strategies during these unprecedented times. So thank you, everyone.